record here.
All right, very good. All right, so I have, my name is Mike Remetz. I'm one of the interventional attendings. I guess it would be a race for Joe Brennan and myself as to who's done more femoral access throughout the years. We are going to talk about femoral access and just general kind of cath lab etiquette today. It's a good introductory topic. I've talked about this over the years. I have no conflicts. I don't receive any money from any of the companies or anything that would sway my opinion one way or the other. What you see is what you get. This is from a conflict from a famous Clint Eastwood movie, Pale Rider. So where he, of course, goes up against 7 individuals and, prevails and saves the day, saves the good guys, so. We're going to talk about vascular access and complications. I wanted to start out with just a word about very basic safety. I mean, you tend to not think about this until you get yelled at. There are issues with sharps that we should all be aware of to avoid a Frank horror show in the lab. Anytime you're in the lab where you're using needles, sharp items, scalpels, etc., we have to pay careful attention to how we handle those devices on the table. You want to minimize your chance for any puncture. Every cath lab kit will have an impaling device for the needles. We also have sharp disposal containers in every cath lab. These should be used when you're done with your case. It is the operator's responsibility to make sure that all the sharps are put in the sharp container and disposed of correctly. Things that aren't cool is to leave them on the table. You don't leave an open needle or an open scalpel on the table. And if you do that, the techs and the nurses will tend to get very upset, because when you're cleaning up and disposing of other materials, you don't want to get stuck. So very important. So it's the operator's responsibility to account for the sharps used during the case. You have to properly dispose of all sharps in approved containers. You never stick your hand in a sharp container. Seems obvious, but of course, every once in a while it does happen. You resheath all scalpels immediately with the automatic resheathing device. You never recap needles. There's, as we talked about, there's the impaling kit. And you have to be just very deliberate in your movements. You don't want to make sudden turns, holding the needle out in front of you. That's how people get injured, and it could be a real mess and a real danger with communicable diseases. The other etiquette aspect is that you will be asked to draw up medications from the nursing staff. You're using intracoronary adenosine, intracoronary nitroglycerin. You always want to use a clean red needle that's a blunt tip to draw up any of these medications from the nurses. They will require you to do that. They will give you whatever needles you need, whatever syringes you need, and you use that to aspirate back from their containers, either an IV bag or a medication vial. Very important that you use the blunt tip needles. So when we're talking about femoral access, we have to go through the basic steps that you use to evaluate the patient ahead of time. And this should be done before you do the case. You'll be discussing how you access the case with the attending. The vast majority of times we will be going radial access. We've already had a talk on radial access, I believe. It's a separate issue. I'm going to be focusing particularly on femoral access. So you do a good pulse exam. You want to make sure you look at both the femoral pulses on both sides. You want to make sure you do a distal pulse assessment. You want to make sure you have an understanding of the landmarks for the patient. And we're talking in general about a micropuncture technique. In the old days, we used to use very big gauge needles to access the artery. My impression and opinion is that when we moved to the micropuncture technique, there was a very marked change in the amount of bleeding complications that we had. There's a lot of advantages that the micropuncture technique has, which we'll go over. You want to look at the femoral pulse. You want to access the side with the best pulse. So you may want to decide that you go to the left femoral instead of the right. Our go-to is the right femoral. If there is a bruit or evidence of vascular disease on physical exam, you'd want to access the opposite side from the bruit. And if the femoral pulses are equal, you want to access the side with the better distal pulse. This is the anatomy that we're talking about. Everything hinges around the inguinal ligament. The inguinal ligament goes from the anterior superior iliac spine to the pubic tubercle, makes a nice line here at the brim of the pelvis. Our access site, it's not this green, the green is highlighting how the femoral artery, you have common femoral artery, external iliac, common iliac, internal iliac, common femoral, superficial femoral, and deep femoral. Our targets are going to be right at or near the inguinal ligament, just below the inguinal ligament. The reason for that, if you look at the lateral view, is that the common femoral artery just distal to the inguinal ligament is right over the pelvic brim, and it gives you a good foundation for, compression of the artery when the sheath is removed. If you go too high, if you go above the inguinal ligament, you're going to have the artery diving deep into the pelvis, and you can't get any compression at all. In addition, you won't have any evidence that the patient's bleeding. They can bleed into that retroperitoneal space without any evidence externally of significant bleeding. If you go too low on the femoral artery, you'll get selectively into the superficial femoral or deep femoral. And also there's a lot of muscular tissue below these arteries. So again, very hard to get adequate compression after removing the sheath. So we want to go to a specific area in the common femoral artery. There are a lot of variations in groin anatomy. You have to take this into account. There are the crease, which many people try to use for identification of the access site, is a terrible indicator of where you are in the femoral artery. Here's what you more likely see in the cath lab, where you're all scrubbed up, you're ready to go. The patient is a heavy patient with adipose tissue, several creases that are visible. None of them probably indicate where you should be sticking. So you have to get other information to try to assess as to where you're going to stick that femoral artery. The best way to do that, in my opinion, is to use fluoroscopy. This is a arterial sheath that's inserted into the common femoral artery. You have, again, the inguinal ligament is right here. Again, pubic tubercle to the anterior superior iliac spine. It delineates the boundary of the pelvis and the common femoral artery and the external iliac artery. You want to be looking at the femoral head. We want to look at the lower 2/3 of the femoral head. And generally speaking, if you try to hit right at this point where the lower third meets the middle third, you will be accessing the common femoral artery, and you will have the greatest success in getting a good stick. So that's kind of your target there. You can, I think it would be acceptable to have a target anywhere within those lower 2/3 of the femoral head. The good thing about the micropuncture technique is that you can look at this on fluoro. We should always be fluoroing the micropuncture needle with the wire in place to see exactly where you have inserted the needle into the artery. If you're up here, which sometimes you will be, sometimes you'll be way too high. And if you see that the needle is up in the external iliac artery, it's time to think about abandoning that stick and removing the micropuncture needle and wire, and then going for another stick further down the artery. Similarly, if you're too low, you want to abandon that stick and try to get a perfect placement in the common femoral. We use the micropuncture technique. The equipment that we have is a 21 gauge needle, an 18 thousandths inch wire, which is very small, fits through that little tiny needle, and a 5 French introducer sheath that goes over that 18 thousandths wire. This is how the equipment is given to you on the table. The micropuncture needle, there's an arrow there that assesses whether the bevel is up. You always want to go into the artery with the bevel up. There's the wire that's included in the kit, and the 4 French introducer. This is, again, representation of the micropuncture technique and micropuncture equipment. This is an ultrasound taken long axis with the artery, which shows the needle entering the artery and in good position. This is a case that we have done at Yale where we want to go through each of the steps. Generally speaking, you would identify the femoral head by fluoroscopy, use a radio-opaque piece of equipment to identify where you are on the femoral head, and try to gauge your entry into the artery using that approach. This is with the stick in place, so the micropuncture needle has been inserted. The wire has been advanced up into the iliac arteries, and you would fluoro that to see the entry site into the artery. So here on the left-hand side, you could see that the needle, it's a little bit on the high side, but the actual entry site into the artery is within that area of error within the lower 2/3 of the femoral head. The wire is safely placed in the iliac system. And on the right side, we see an angiogram after the sheath has been inserted. You can see that the sheath insertion is in fact in the common femoral artery with good position in the artery. This would be a good kind of textbook stick. Once you have that micropuncture wire in place and you're satisfied with it, you would remove the smaller introducer inside the small micropuncture kit and insert a larger wire. You go over a 0.35 inch J wire, and that's inserted up the artery, and then that is used to put in the sheath that you will perform the procedure with. That's usually a 6 French sheath if you're doing a coronary intervention. Most of our guides are selected at a 6 French size, so that's the kind of standard size for French size when you insert the arterial sheath. Just a word about the wires. Our standard workhorse wire is the 0.035 inch J-tip wire. It's a very good forgiving wire, tends to navigate large vessels very well. Generally speaking, it's atraumatic. It follows the vessel. You have good visibility. It's very flexible. There's some downside that you cannot steer it. So you can't, if you do have a small part of the vessel or you're trying to get in a side branch, you won't be able to steer the tip of this wire. And if there is a tight stenosis, this wire generally will not cross. If there's a really tight stenosis, it just bangs off the side of the plaque. And you don't want to do that. You don't want to persist in that type of behavior. If you keep persisting with the wire and you're stymied by a plaque, you're eventually going to dissect the plaque and get subintimal, and that's something you, of course, want to avoid. So just a word about components of an arterial sheath. They are labeled as French size. 1 French equals 1/3 of a millimeter. They are generally color-coded on the sheath by French size. It was this kind of naming nomenclature was developed by Joseph Frederick Benoit Charret, who is French. So that's where the French size comes from. You have a side port, which accesses the artery. You can aspirate through that side port. You could also do pressure monitoring through that. There's a dilator that is inserted through the sheath, and that accommodates the 0.035-inch guide wire. It allows you to enter the artery atraumatically. And there is also a hemostatic valve here. After you remove the dilator and wire, the arterial sheath will be sitting in place in the artery. And there's a hemostatic valve that prevents back bleeding, but it allows catheters to be inserted. So femoral access, what are we talking about in the big picture? It's technically quite easy. When patients do not have vascular disease, there's usually a good pulse, and it's an easy artery to hit. It's a large vessel. You can insert large devices. You can get huge French size if you need that type of size for a sheath with, for instance, TAVR or cardiovascular support devices. The femoral artery in a normal-sized human will accommodate very large devices. The other thing about femoral access is that there is very easy coronary engagement. The Judkin catheters are, kind of idiot-proof. They cement aorta and they'll fall right into the coronary. So very good for access. There is low radiation exposure to the operator. It does have disadvantages that primarily hinge around vascular complications. In my opinion, in the literature suggests that there are less vascular complications when you proceed with a radial approach. You need to, for femoral approach, you need to have bed rest for 4 to 6 hours, and it's generally more uncomfortable for the patient. So thus it is our second choice for access nowadays, and most of the cases that we will be doing will be from radial access. We want to go over special situations that make femoral access difficult. If you have a severe stenosis or occlusion, it obviously will become very difficult to get in the femoral. If the vessels are tortuous, you can get into problems with inserting the sheath or advancing the wire, or having the sheath in the artery, but then becoming kinked, and you can't advance equipment through it. Patients that have had prior vascular surgery become difficult. You generally don't want to be inserting sheaths into Gore-Tex grafts from either the aorto-bi-fem graft patient or the fem-pop patient. There's also patients that have had multiple Caths, and they tend to get scarring, and it's difficult to insert the sheath. So we'll cover all these situations as to what type of things we should be thinking about when you encounter this difficulty. There are special wires that we sometimes use. If we cannot traverse the iliac system, you may think of going to a more steerable wire, and this is a Terumo hydrophilic coated glide wire, and it is a 0.035 inch glide wire. It is has a good visibility to the distal tip. It has an angle that allows you to steer either into a vessel or through a stenosis. So this is the kind of thing that we would be using in severe vascular patients. It's a very slippery wire. You've got to be very careful with it. If it is wet and you're holding it, sometimes it sticks to your hand and it just comes right out of the body. You have to be very careful when you're using this wire that you that it doesn't slip out of your hand, or that you move it appropriately. It generally has good visibility. You can still traumatize vessels with this wire. It will easily enter small branches, so you have to be careful that you're not getting into a very distal branch, and because it is so slippery, it tends to perforate. So it could be problematic from that standpoint. The other caveat is that you would never use this wire through a metal needle. It has a kind of a polymer coating, a polyurethane jacket, and the metal needles can actually shear off parts of that jacket at the bevel. The cutting edge will carve off pieces of that, and you can actually get distal embolization if you do that type of thing. If you have a tortuous vessel, it's good to think about the metal braided flex sheaths. They are very hard to kink. They follow the artery tortuosity very well. And if you get into trouble with maneuvering catheters, you can actually even put a very long sheath in, so you can kind of traverse the area of tortuosity. You can use a 40 or 60 centimeter long sheath, get up in the ascending aorta, and get around any areas of severe tortuosity. And you'll usually find that your guide catheter manipulation is a lot easier. If the patient has had prior vascular surgery, you want to try to puncture away from the grafts. You try to get either above or below a presumed Gore-Tex graft. You would give preference to sites that are away from the graft. You can puncture through a graft, but you got to remember that your complications will likely be higher. It is more difficult to seal those grafts after arteriotomy, so you want to show extra caution when you're doing that type of thing. If you have scarring at the site that doesn't allow you to ensure and then you gradually work up to, in French size, to the dilator that's appropriate for your sheath that you want to insert. A lot of times the patient's skin will prevent insertion of the sheath, so you want to make sure you have a scalpel nick that's appropriate for the patient, a good generous nick that'll accommodate the sheath. Stiff wires will help in this situation, where you use a wire that doesn't allow any deviation from the pathway into the artery and gives you quite a bit of force to insert a sheath into the artery. The Omplot's extra stiff is our kind of go-to stiff wire. If you can't hit the artery, ultrasound guidance can be used. It takes a lot of the guesswork out of the approach. In my opinion, I think we should almost be using ultrasound guidance on every femoral case. You'll probably get pushback if the lab is busy, but I think it's a learning institution, and we should be learning how to use this when you really need it. And in addition, it's my opinion that this makes access safer. Not only can you see where the needle is going to go into the artery, you can see the artery, you can see the needle going into the artery. So you get a very precise approach, but you could also see if there's plaque there, you could identify plaque, and you could identify the bifurcation. There are some patients that are going to have higher bifurcations, and it may help you insert the needle in a patient that has unusual anatomy with a very high bifurcation of the superficial femoral and profunda artery. I just wanted to look at vascular complications. This is an old study, but it was a randomized study using radial arteries and femoral artery approach. Large hematoma was in fact more common, although a relatively low incidence, 3% in the femoral approach, as opposed to a 1.2% in the radial cases. I think we're running lower than that. I don't have our latest statistics, but radial approach in my last several hundred cases has been very good for minimizing any hematoma or access site problem. So as you get better and better with radial, you learn how to kind of cherry pick your cases and do a real good job. And I think our complication rate we would expect to be certainly 1% and maybe less than 1%. Femoral artery, it's going to be more of a crapshoot. You're going to have patients that will have complications no matter what you do. And I think that 3% number is a representative good number. I also noticed that the incidence of pseudoaneurysm was higher in the femoral cases. So this is what we're dealing with. Are we dealing with an obsolete technology using the femoral? Many things come and go. It certainly has decreased in frequency of use. I think when we talk about whether it's a dead and gone technology, there are certainly cases where we have to use femoral access, and I've listed them here. There are radial cases that aren't suitable because the patient either has an AV fistula already for dialysis, or they have planned dialysis and possible fistula in the future. Those patients, you should consider using femoral approach. If you have a failed radial access already, there will be a percentage of patients which, because of vessel tortuosity or because of radial loops, you won't be able to get radial access into the central aorta. We would routinely abandon that approach and then go to the femoral approach. Many of our older patients have very tortuous subclavian and brachiocephalic anatomy. These patients you might consider starting out with a femoral approach right off the bat, especially if they have a lot of skeletal deformity. There also are patients that you get into the ascending aorta with the radial approach, but you can't engage the coronary. So you have to, there's going to be a handful of patients that you will have to switch access site because you just can't get any of the catheters to work. It's probably better to move ahead and quickly decide going femoral access rather than persisting with about 50 different catheters, because that you could get a sense after doing this for a while that some of these anatomy of the ascending aorta from the radial is just not conducive to coronary engagement. There will be patients that you don't have a radial. Some of the procedures that we do are required radial access just due to the size of the equipment that you're using. That would be TAVR patients, any other structural procedures, Impella patients or balloon pump patients. Certainly lower extremity PV procedures require femoral access. And if you are going to require a large guide catheter, you'd want to go femoral access. And also the more advanced ECMO type of cardiopulmonary support would require femoral access. I just wanted to put in a plug for the French system. This is, a tiny little sheath. And if you are pretty sure that you're going to use a diagnostic case and not doing an intervention, it's worth thinking about this approach. They are 1.3 millimeters in diameter. That's really small. And our 4 French diagnostic catheters have advanced to the point where you can get pretty good diagnostic angiography with these catheters. So in my opinion, the 4 French catheter with a manual hold of that small arteriotomy, you would expect a very low rate of bleeding complications. So it is something to think about initiating when you have to do a femoral, especially if you think it's going to only be a diagnostic case and the radial site can't be used. So I want to move ahead to femoral access site complications. Just give me a moment here. I'm going to bring up something else. Okay, sorry for that delay. This is a patient that, is kind of representative of a complicated case. The patient has had significant bleeding after the sheath was removed and a significant hematoma. And this is by far our most common access site complication from the femoral site. It is painful and can lead to further problems. You can get this type of thing can lead to pseudoaneurysm, significant anemia, need for transfusion. All these problems can arise from a significant hematoma. It's worthwhile going over the literature definitions of bleeding. You have the TIMI bleeding classification. A major bleed would be considered an intracranial hemorrhage or a fallen count of greater than 15 for the hematocrit. A minor bleed would be hematuria or hematemesis, and a fallen count of less than 10 for the hematocrit, and fallen count without a source of greater than 12. All other bleeding would be considered mild. What is a major bleed in the rival trial? It was considered either a fatal bleed, transfusion of 2 or more units, hypotension and the need for pressors, need for surgical intervention, causes a disabling sequela, or intracranial or intraocular loss of vision, or a 5 gram or greater fall in hemoglobin. So if you look at the rival trial, which was a very large, randomized, well-conducted trial of femoral access, you see the following statistics. Non-cabbage major bleeding would be 0.9%. A large hematoma, which we went over before, would be 3%. Pseudoaneurysm would be less than 1%, but still a significant group of patients will have a pseudoaneurysm formation. And then you get into other rare complications, AV fistula or an ischemic limb, persistent pain. You can see that if you add up all the major vascular complications, you get 3.7%. If you have all major bleeds plus a vascular complication is 4.5%. Femoral brachial complications, if you look at the brachial approach, these are numbers from a site that looked at the brachial. This is an obsolete approach, but just to show there are significant hematomas that can occur with that. This is a breakdown of the type of frequency of complications. If you actually follow patients out, there are studies here. This is from the Journal of Vascular and Endovascular Surgery. They had a higher incidence of pseudoaneurysm, so almost 50% of their significant complications in this series was due to pseudoaneurysm, with second in line being bleeding and hematoma. If you look at the frequency from older data, you can get, particularly when looking at older interventional trials, the hematoma and transfusion rate can be as high as 7% from femoral access. Retroperitoneal bleed should be less than 1% using our approach that we've outlined previously. And I think it's important to note that over the first part of this millennium, there was a noted decrease in vascular complications when you look at large national databases. And this is explained through, likely due to changes in technique, which we'll kind of go over. Bleeding is, of course, a nasty complication. If you look at bleeding, and this is days in the hospital, post-catheterization, and looking at mortality, those patients that bleed have a higher death rate. And you can kind of understand that. They also have other things that make them high risk, but bleeding is a good marker of mortality. And if you don't have a bleed, your mortality is less in the hospital. This also extends out to long-term mortality. If you take bleeding patients at the time of a catheterization and compare them to no bleeding, there's a higher long-term mortality. So again, indicative of other factors that make patients bleed. What are the other factors and the predisposing factors for femoral bleeding? If you have, you can have anatomic factors. This would be calcified vessels, elderly, obese, female, combative patient. You can have procedural factors. If you hit the back wall of the artery, you either have a high or low puncture, multiple punctures, a large sheath, sheath kinking, prolonged procedure, prolonged sheath. All of those procedural issues can lead to higher rates of bleeding. And you can have hemodynamic factors, patients with aortic insufficiency or hyperdynamic circulation with an increased pulse pressure or hypertension have a higher risk of bleeding. And of course, we give a ton of medications, antiplatelet, antithrombotic, lytics, any patient that has a coagulopathy. All of those would be hematologic factors for bleeding. Very important to think about your hemostasis technique also to reduce bleeding complications. It will require that you, have a long enough hold for the femoral arteriotomy to make sure that you get an adequate seal of that femoral artery. Heparin is an important thing. If you look at heparin administration during PCI, the ACT is a very indicative index of your bleeding rate. If you get too low, you tend to get problems with thrombotic complications in the coronary, and those patients also bleed. The sweet spot for, in this study, was in the 300, high 200, 300 range, where they had the lowest bleeding complications with those patients. If you get too high with the ACT, you're going to increase your bleeding complications. So very important to keep this in mind. You want to aim for the sweet spot of 250 to 300 for our ACT values during PCI. This is an old study, but worth looking at. This kind of shows from the old EPIC study, which was a study of stents and ReaPro. It shows that the ReaPro patients in this study had a much higher rate of major non-CABG bleeding, up as high as 10%. As you go along with time, these were similar trials looking at ReaPro administration during intervention, but they were at different time eras. And this was getting into the early 2000 era, where you can see that the ReaPro patients had a very low non-CABG bleeding in the EpiStent trial. During this time period, we did a couple things. We used to take an 8 French sheath, and sew it in place, keep it in place overnight, keep the patient on heparin and ReaPro, and that's the standard for EPIC. And so it was thought that that type of approach led to higher bleeding complications versus the EpiStent trial, which had moved ahead to smaller sheaths and removing the sheath immediately after the procedure was over. And using that kind of approach, your major bleeding rate is much lower. And that's our standard today. We do not leave sheaths in overnight. We try to get the sheaths out as quickly as possible after an intervention once the ACT is less than 180. This is again from in-hospital bleeding, looking at the interaction between 2B3A inhibitors, abcicimab, and versus stent-only cases. Very interesting that you would think, well, the ReaPro and abcicimab approach with stents must be a higher bleeding rate, but that was not borne out in the data, where if you look at all major bleeding, the stent group alone with the higher ACTs tended to show higher bleeding rates versus using a 2B3A inhibitor. Similarly, the strokes were not statistically significant when you use 2B3A inhibitors. There were, in these trials, in the EpiStent trial, there was no hemorrhagic strokes. So it's coming down in favor of it's easy to think that anecdotally there's a higher bleeding rate with 2B3A inhibitors, but if you pay careful attention to your ACT, careful attention to sheath removal, these agents can be used very safely. This is information concerning Bivalirudin and bleeding complications. In Greg Stone's trial, there was a lower incidence of bleeding with Bivalirudin when used in combination with PCI. And so what do we do from a kind of a teleological approach to preventing bleeding complications? From the prior data that I've shown, we want to avoid post-procedure heparin. We want to get the sheath out early. We want to use smaller size sheaths. You want to pay attention to the access site and attention to access technique that we've gone over. If you do have a hematoma, it's fair game to try to express that hematoma with a more vigorous skin nick and to try to remove the hematoma before it causes a problem. The hematoma is frequently the substrate that gets you into trouble with pseudoaneurysm. You want to avoid high-dose heparin. You may consider using agents like Bivalirudin. And of course, our go-to access site would be the radial access site. Closure devices, I don't have a lot of data on closure devices. It's probably worth another talk, but closure devices probably reduce bleeding rate, but they give you their own set of complications. I wanted to cover retroperitoneal hemorrhage. This is the most dreaded complication from femoral stick. The risk factors are listed here. First of all, it should have a very low incidence, which should be less than 1% for overall retroperitoneal hemorrhage. The risk factors are high arterial puncture, back wall puncture, female gender, low body surface area, and post-procedure anticoagulation. It does not seem to be that associated with sheath size, although I've already given my shout out to the 4 French. I have never seen in my cases, including other operators, I've never seen a big retroperitoneal hemorrhage post 4 French catheterization from the femoral approach. There does seem to be a lack of association with RP bleed with closure devices. You probably have other problems that don't, that come from the closure devices that would increase your risk of bleeding. And it doesn't seem to be related to the use of 2B3A inhibitors. So signs and symptoms, they can be very, somewhat subtle in the sense that the first thing that you usually have is hypotension, and that's a very frequent, and you don't have any external bleeding. The patients are usually bleeding up into their abdomen. So as far as bleeding outside of the body from the actual arteriotomy site, you usually don't see that. the patients get very sick. They get abdominal and groin pain. They get diaphoresis. They get bradycardia. They get back pain. You want to think about this in any patient that has had a femoral stick that you get called for hypotension. And you want to think about ways that you can modify that bleeding. You want to reverse the anticoagulation with protamine as soon as possible. If the patient has had a 2B3A inhibitor, particularly abcicimab, you would think about platelet transfusions, and you want to get large bore lines in place to volume resuscitate the patient. You want to get them into a imaging situation with a CAT scan as quickly as possible to identify the presence of a retroperitoneal bleed. And we generally now would approach these patients with a quick return to the vascular lab for possible intervention to either treat these patients with a balloon tamponade from endovascular approach or a possible covered stent if the stick is above the inguinal ligament. I wanted to go over a case. This was a very sad case that had a carotid artery stent, so of course had to have femoral access. No closure device was used. The patient came up from the carotid stent to the ICU and had a femoral sheath sewn in place. The ACT was very high post-procedure. The procedure was concluded at 2:30. The sheath was removed after the procedure. This is his arteriotomy following the arteriogram following the procedure. And it shows that he had atherosclerosis of the iliac artery. And you can see that it is in fact a high stick. That sheath is inserted into the artery up around this region. So you're talking in the pelvis, above the inguinal ligament, above the pelvic brim, and very high stick. This would be, if we see this type of arteriogram following a procedure, hopefully you'd avoid this altogether by appropriately abandoning a stick if it is this high. But if you do have a documented arteriotomy, I would make the case that we should be treating these patients in the lab to remove the sheath. So you would have immediate access to balloon tamponade technology and covered stents should the case go wrong. So the patient had a long kind of stormy course in the ICU before this was recognized. He kind of got the low road approach where he had a fluid bolus and phenylephrine to support his blood pressure. It was complicated because they thought that he had a stroke because he was kind of unresponsive and confused, and some people were calling him dysarthric. So there was a delay in this diagnosis just because of the concern for the carotid stent. So things went downhill further. He was still functionally anticoagulated with a high PTT. They did a head CT, it was normal. And I'm just gonna go through this fairly quickly. He eventually had the sheath removed and had a severe bleeding, and he was brought to the CT scan late at night, 9 p.m. And I'll go over this is the CT scan starting up in the chest. As we work our way down, we see the liver, but you can see in this area start to pick up evidence of RP bleeding. We're now getting below the liver, but you could still see there's this is again, this doesn't require contrast to get this type of scan, but here you can see all the blood that's accumulating in the retroperitoneum. All this area on the patient's right side is due to blood accumulation. This is a massive retroperitoneal bleed, and this is what you would see by non-contrast scan. although they did give contrast here, but this, you don't need contrast for this type of approach. You see massive RP bleed with abdominal distension, movement of the abdominal organs off to the side. This is again getting down to the level just below the level of the kidney. Still see this massive bleed, now getting down into the pelvis, and you still see all this blood material here. So very bad CT scan showing significant bleeding. The patient was taken back to the Cath lab, and I believe we have. So if you look at this area here near the right femoral, we're near the access site, you could actually see during the angiogram, there's extravasation of blood out of the artery. So there's an active bleed right at the arteriotomy site, which could not be compressed. And then this is another view, another angiogram showing the active bleed at that right at the junction between the external iliac and the common femoral. Massive bleed. There it is on subtraction. He again showing the atherosclerosis with the active bleed. And here's a balloon tamponade of that area. The patient stabilized to some degree when this was done. And this is after placement of a covered stent over that area, which you could see on this angiogram, the bleed has been sealed. But unfortunately, the wait was too long. He had problems with massive pressor use. He developed an abdominal compartment syndrome. So all that accumulated blood increased intra-abdominal pressure tremendously. General surgery was consulted, but they did not want to go with any emergent surgery. Patient did not have developed anuria. These is the blood products that were used, huge 12-unit transfusion, 12 liters of saline, 5 units of platelets, cryo FFP. But here, this is the bladder pressure when measured was up to 38. So that intra-abdominal pressure was 38 millimeters of mercury, a massive increase in intra-abdominal pressure. This is a devastating complication because you get ischemic complications of most of the abdominal organs, including the legs, can become ischemic. And unfortunately, the patient did pass away from this event. So this is the type of thing that we want to be wary of and try to jump on things as early as possible. What you would start thinking, any patient that gets hypotensive post-cath or has severe pain post-cath, you should be thinking about getting your CT scan and making your diagnosis of possible RP bleed. So again, risk factors for RP bleed: high stick, non-compressible stick, unable to use a closure device, female gender. We talked about the idea to remove the sheath in the lab if you see a high stick, and you could access the contralateral site for any of your procedures. This is the complications. I mean, we're all familiar with this stuff where you get, severe complications from significant bleeding, ATN, shock liver, ARDS, organ compression, and venous compression. We've even seen patients over the years that have developed DVTs and pulmonary emboli after a retroperitoneal bleed. This is usually something that develops several days out. You've reversed all the anticoagulation, but because of the compression of the venous drainage, you would have a higher incidence of problems with thrombotic issues. So you're now talking about anticoagulating a patient that has just had a massive bleed. So very problematic. This is just kind of a little bit, the next part of this will be kind of a little bit of show and tell of what people have done to help with perforations and things. This is a common femoral perforation. I would not do this literature. Probably better to involve vascular surgery very early and go in for a very quick suture of the area. Rather than have a common femoral covered stent, which can get into problems with lower extremity ischemia, the vascular surgeons are very good in this area and can sew up any significant problem with the femoral artery. Sometimes if you have a lacerated branch, when you're putting your stick in, you can actually hit some of these smaller branches that come off of the external iliac and common femoral, and these can be treated with coil embolization. We have several cases where the vascular specialists have coil embolized bleeding areas from this type of laceration and arterial injury. We should spend a little time on a pseudoaneurysm. The causes are what we have already talked about. If you have inadequate compression, a high or low stick, if there's a low stick in the superficial femoral, these are the kind of things that would set you up for inadequate compression and pseudoaneurysm formation. Most of these patients will have severe pain at the site, and you will hear a bruit. If it's greater than 3 centimeters by imaging, the go-to imaging technique would be ultrasound. If it's a large pseudoaneurysm, we have had a inclination to close those. I'm not going to spend a lot of time on ultrasound-guided compression. It is primarily an obsolete technique. Surgical repair can still be done. Our go-to correction for these pseudoaneurysms is ultrasound-guided injection of thrombin. I'm going to skip ahead to that. So when you inject thrombin into these pseudoaneurysms, you have a higher technical success versus guided compression. You can have the pseudoaneurysm seals up in a few seconds with the thrombin injection versus prolonged compression. If you just press down on the thing, the patients tolerate it better. You don't need to give them painkillers or sedation, and it's effective even if your patient needs heparin or warfarin. And you could even do it if pseudoaneurysms arise above the inguinal ligament. What's done is that you identify the pseudoaneurysm sac and insert a small needle into the chamber and inject the thrombin directly into the pseudoaneurysm sac. This is an example of that, where an ultrasound showing a large 4.2 centimeter pseudoaneurysm. The neck is well identified. Here's the needle inserted into the pseudoaneurysm, and this is lack of flow after the pseudoaneurysm has been clotted off. There are all kinds of odd approaches with pseudoaneurysms. Doing a CT angiogram can identify these things. Every once in a while, you stumble across this type of thing in a patient that's had a cath. But there you see a large, complex pseudoaneurysm that's been identified on a CTA. Here's one that's been identified by angiography, large pseudoaneurysm here. And, generally speaking, this is a case where someone occluded the artery with a balloon in order to give thrombin. And that type of thing is not advisable. We really don't need to do that. You can get a very high success rate of pseudoaneurysm closure just by ultrasound-guided injection. I'm not going to, it's getting late in the hour. Thrombotic occlusion rarely occurs. I'm going to skip over this, and I think we're going to call it a day here. We've hit the big complications, I think we should, when you're in the cath lab as a learning fellow, the biggest thing is to not be a cowboy. You really want to don't, if you have any doubts about how to proceed, you should fully understand the situation. That usually means getting advanced people in there, either a senior fellow or an attending, to make sure that you're doing the right thing and not flirting with disaster. This is good rules. Go slowly and gently, think logically, stop if you don't understand something, and ask for help. Always good rules to live by in the Cath lab. So that's the end of my talk. I'd be happy to entertain any questions. Thank you very much.